So welcome to this session, PD14, long COVID, the aftershock of the pandemic. I welcome you here. You're in the right place. There is at the moment also another session focusing on the distribution of vaccination, which we completely believe is a highly relevant topic, but we are looking a little bit ahead. While everybody has to focus at the moment on that vaccination distribution, we think there is another real big wave coming, and that's the aftershock long COVID topic. And I'm very happy and proud that I am here together with a number of experts. My name is Georg Duda. I'm heading the Regenerative Research Center at the Charité, spokesperson for the steering there. And we're focusing on innovative advanced therapies, personalized therapy development. But we are also very dedicated focusing on strategies to treat long COVID. And it's a great pleasure to be here with a whole group of experts. We will organize the session in the way that we have brief talks and statements from the experts here in the beginning, 10 to 15-minute statements, and then we open the floor for discussion among us to debate. We have 3 speakers here in the room, and we have one speaker online from Boston, who has the big challenge that he is in a completely different time zone, and I'm very happy that he's already up in here. I'd like to introduce first our speakers. Carmen Scheibenbogen is going to give the first impulse, and I'm saying a couple of words to her in a second. We have then Nina Babel, who's going to illustrate strategies of advanced therapies in that domain, as well as conventional repurposing strategies. And we'll have Yehuda Schönfeld giving his view from the Tel Aviv University. And finally, Ross Zafonte will give the Harvard Medical School view from the Spalding perspective. And thank you for being awake already at that early time point in the East Coast, at the East Coast. Carmen Scheibenbogen is going to give the first statement. Her expertise is in immunology. She is a professor of clinical immunology at the Charité and deputy chair of the Institute of Medical Immunology. And her focus is on clinical immunity deficiency at the Charité. She initiated a long COVID clinical unit to develop strategies on how to treat and deal with that challenge. And I think we should start directly with Carmen Scheibenbogen's statement. Carmen, the floor is yours.
Yeah, thank you. Hello, good morning, everybody. I'm excited that I have the opportunity to talk about this important topic, the many facets of long COVID. And that's the situation we all have learned during the last 12 months, that we have many people who have persisting symptoms after resolving from COVID. And we learned too that these are actually many young patients who had only mild COVID. And we also learned that there is a long list of symptoms these patients report of. And what I think is very important now is that we understand the different symptom complexes and diseases, which actually are under the term of long COVID summarized. And then by following this subtyping, we need to understand the mechanisms, and based on this knowledge, we then can develop targeted therapies to help and cure these people, because we have learned too that many of them are now chronically severely ill. So I brought to you this slide that's from the German population study, which was just archives 3 days ago, and they studied more than 150,000 people who had COVID and followed their symptoms from 3 months on after the infection. And they categorized the symptom into 13 diagnosis symptom complexes. And what their study shows is that actually all of these symptom complexes were more frequent in those who had COVID. And that's true for both adults and children among 11 years of age. And what they also showed is that although those who were treated in the ICU have more frequent diseases and symptoms, that is also seen in many outpatient clinics. So I think what is very important now is that, first of all, we need to clinically phenotype these different types of symptom complexes, because the majority we cannot give a known diagnosis so far. And for this, it's helpful that we have now the WHO criteria, which were defined following a Delphi consensus. And I'm going to summarize this COVID or post-COVID syndrome definition in a moment. And I think it's also very important when we deal with long COVID that, first of all, we should subdivide patients into those who had a severe course of disease. And in these patients, we see a lot of what we call ICU sequelae. So these patients do have a lot of long-term problems. And these are not only related to the COVID infection, but also to the intensive care treatment. And we have in this group also a subcategory in which we can give the diagnosis of well-characterized diseases. We have mental health disorders, we have pulmonary disorders. In the younger who only had a mild to moderate COVID infection, and that's something which was surprising for us in the beginning. We also do have a relevant number of patients who do not recover, and based on the epidemiological studies we have so far, there's about 10 to 20% of patients. And coming to the WHO definition of post-COVID condition, these patients have to have symptoms 3 months, persisting symptoms 3 months after the infections, which have to last for at least 2 months. And the main symptoms are fatigue, shortness of breath, cognitive dysfunction, post-exertional malaise, but also others. And the criterion is that these symptoms have to impact daily life. For many of these patients, we do not have diagnostic criteria yet. However, there's a subset, and these are probably the most severely ill, who do fulfill the criteria for ME/CFS, or myalgic encephalomyelitis chronic fatigue syndrome, a disease which has been known to be triggered by various other conditions like EBV or influenza. I'm coming to this disease in a minute as well. And then, of course, we have to face also many patients who have developed diseases as lockdown sequelae. And these include psychosomatic diseases as well as mental health disorders. So ME/CFS is a special disease in many ways. It's actually a quite frequent disease, a severe, complex, and chronic disease. As I said, triggered by various infections with a quite high prevalence, varying from 0.3 to 0.8, depending on the study. That was a prevalence before COVID. It has a preponderance of females, and it's a disease of younger people. And its key symptoms are the severe mental and physical fatigue, exertion intolerance, post-exertional malaise. So these are identical symptoms the majority of younger long COVID patients report. They have neurocognitive symptoms, headache, muscle pain. It has been long misjudged as a psychiatric or mental disease or depression. Therefore, mechanisms are not well understood until today, and there is no specific therapy yet. And now looking at post-COVID syndrome, ME/CFS, so this actually fulfills the same diagnostic criteria as we know, for example, from EBV. And again, we have this female preponderance. It's a disease of younger patients, and about 50% are unable to work. This is data from our own ongoing study at Charité. The incident rate increase is from the larger cohort studies about 2 to 3-fold in the post-COVID cohort. However, this is probably much higher, and this is due to the fact that many physicians are still unable to diagnose this disease. This is based on a recent study we performed within our European network on ME/CFS called Autoimmune. And this is probably also reflected by the fact that those physicians who are familiar with this disease, they report on much higher numbers of ME/CFS following COVID. So the good and important news about long COVID is that during the last 12 months, there were many studies and many studies reported already on mechanisms which may be of relevance for long COVID. And on the last slide, I summarized the two most important mechanisms we think play a role in long COVID. That's on the one hand, low-level inflammation, and on the other hand, endothelial dysfunction or microcirculatory impairment and hypercoagulability. And that both makes a lot of sense because the virus induces a strong, long-lasting immune response, which may result in dysregulation of the immune response. And the virus can infect endothelial cells and therefore may result in long-term dysfunction of vessels. And the role autoimmunity plays is not so clear yet. But as Yehuda say, autoimmunity should always be considered as long as we don't have another clue for the mechanism. I think that's an important topic too, and Yehuda will talk about this later on. And then finally, I brought a list of drugs which are already in clinical trials. Several of them are already licensed for other disease, and that gives hope that we will find in the near future a treatment for these many, I think, millions of patients who currently suffer from long COVID. And by this, I hand over to my fellow speaker. Thank you.
Thank you, Carmen, for that first impulse. Now I would be happy to ask Nina Babel on stage. Nina is the head of the Center for Translational Medicine and Immune Diagnostics Laboratory at the Ruhr University in Bochum, and also a PI, principal investigator at our Berlin Institute of Health Center for Regenerative Therapies at Charité. She has a clinical training in internal medicine, nephrology, and immunology, and is a long-term expert in characterization virus-immune system interaction. And we're very much looking forward to her statement. Nina, the floor is yours.
Thank you, Georg. Thank you for the nice introduction. And it's really honor and pleasure for me to talk on this summit. And my task today to shortly present you the role of cellular immunity T cells or T lymphocytes, just to be able to target or to combat COVID or severe COVID or post-COVID disease. So just to stick what Carmen told us before, how can we approach pathogenesis or development of COVID in our patients? And we have, if we want to combat this left side, the low-level inflammations that provided by interaction between the virus and the immune system, we have to consider specific immunities, as adaptive immunity that develops during the infection. And antibodies are pretty known for the infections. They are really important to combat the infection, but less known are T cells, but the T cells are crucial. They are not crucial because I'm working on T cells for many years in context of viral infection, but they are crucial, first of all, for production of antibody. If you don't have T cells, we are not able to produce antibodies. On one hand. On the other hand, the T cells, they are also essential to kill virus-infected cells. Just to demonstrate how important they are, if you don't have antibody, we can get infected. But if we have enough T cells, and their T cells are strong, we'll be able to combat infection if we don't have a severe infection. So they are really important for protection. But what we know in case of COVID-19? At the beginning of pandemic, we didn't know what is their role for severe, for critical infections. The patients, they are on the ICU and have a lung damage. And we didn't know whether this patient actually are able to produce these cells. And surprisingly enough, we demonstrated with these gray bars that the patients that have a critical course of COVID-19, they are not even able to produce that. The number and functionality of these T cells were even superior as compared to patients that have less severe course of COVID-19. And what also was shown that these T cells, that lymphocytes, infiltrate the lung. You see on the right side the microscopic picture of the autopsy of patient who died due to the lung failure. And these blue points, they demonstrate the high number of lymphocytes that just infiltrate the tissue and they just damage the lung. So that is what we know about their natural course of COVID-19, but what is about their post-COVID symptoms? And to be honest, there are not so many works on T-cell immunity, specific immunity, and post-COVID symptoms. It's just one study I found very important to show as they author compared the number of T cells that circulate in blood of patients that have a long term of symptoms, more than 3 months, and compare them the patients is their yellow line. I'm sorry, I cannot guide you through the slide. And on their other side, they looked at the T cell number functionality of patients that have a rapid decline of symptoms. And as you can see here, this in the middle, you have the number of T cells. They have a sustainable high T cell response of patients who had a long term of COVID symptoms as compared to the decline of the blue line in patients who recovered quickly. So what is actually the possible pathomechanism of this situation? In the middle of this situation is the ability of T cells to reactivate if they found on this, the T cell receptor can bind to the part of the viral protein. You can see here with an arrow that demonstrates the T cell receptor binding to the part of the virus. The cells can be activated, and they just can kill their tissues and cells that that represent this part of the virus, infected cells. But the problem is that these cells can react not only against the virus, they can also wrongly recognize parts of our tissues, our own tissue, like here muscle cell, that also present a part of the protein, but the protein between a virus and a muscle cell, they are pretty similar, they mimic of the structure of the virus protein, and therefore the cells will get activated and can so attack the muscles. And that is in the middle of this so-called autoimmune process. I'm sure Ahuda will tell you also a couple of words about this, but just demonstrate what could be the possible pathogenesis of long COVID. We have 2 columns. On the one side, there are some studies demonstrating viral persistence for many months after the resolution of even mild infection with SARS-CoV-2. They showed as the upper space of their slide, you see the microscopic picture of bowel cells that present parts of the virus of SARS-CoV-2, and these patients are able to demonstrate in bowels many months after the resolution of the disease on one side. On the other side, this will activate T cells that just react against the virus, and they can go to their cells of our tissues, like muscles or cells of central nervous systems, and other damage them, like autoimmune, providing autoimmune effects, and cause probably the symptoms that Carmen told us a couple of minutes before. They also are ready to help B cells to produce antibodies that they think also Yehuda will tell us, and they have a damage of the tissues and have a symptoms. So what can we do to protect this? First of all, we need to take care of their duration of the disease. So we know the longer the disease is going on, the more damage it is, and therefore we would need to combat infection as soon as possible. How can we do this? Like take antivirals, but unfortunately, up to now, we don't have virostatics or drugs that can combat viral infection, prevent replication of the virus on one side. On the other side, we can also try to boost our immune system to give their vaccine and just to reactivate T cells or also antibodies and other cells to combat, control viral replication. But it works if we have a low level of inflammation in the body. But in case we have already a prolonged case of viral replication, we have a high viral load, we have inflammation in the body, we have a tissue damage, this boosting of immune system is rather harmful. In this case, we need rather diminish the immune response. And what can we do? We could provide immunosuppressive therapy, as also already is doing on the ICU. We can also provide anti-inflammatory drug, just to reduce inflammation. And talking about advanced therapies, there are also a kind of cells that can counteract with these harmful cells. They can regulate their function. They're called regulatory T cells. And these are studies that are not yet started, but we are thinking about this and generating and BCRT. So another column, I told you this is coagulations, the abnormality in coagulations, and just let me to tell a couple of words at the end of my presentation. Actually, in normal situations, coagulation is a physiological process that just help us to prevent bleeding. If we have, let's say, cut our finger and we destroy vessel as a wall, they start to produce factors that cause coagulation in the vessel, and together with platelets, they build clots. They block just the damaged wall, and we don't bleed anymore. But at the end, so in a couple of minutes, we need to restore circulation in the wall, and we have also factors that are anticoagulants presented here, like scissors. And these scissors, they just cut these conglomerates, it's clots, and we have at the end we have circulation in the vessels. That's just how it works normally. In case of COVID-19, we have a process that we call immunothrombosis. What is going on? That is their interaction between three important parts of three important players. On one side is there's cells and molecules of immune system. On the other side is the cells of vessel wall, and then that is also platelets or factors of coagulations. So what is going on? If the vessels of their cell of the vessel wall are infected, or they are just damaged by inflammation, they just die, and it's caused even more inflammation on one side. And then these dying cells also, the damage in this vessel wall cause the production of coagulatory, these factors that produce coagulation in the vessel on one side. On the other side, they also activate platelets, and they build conglomerates. You see on the right side, this platelets, a lot of platelets. What we need now is these scissors that just cleave these conglomerates, these clots. But we have so many factors, coagulatory factors, that then physiological production of these scissors is not enough to cleave these conglomerates. Just to summarize what I told you before, we have a disbalance between coagulation factors presented in red circles on one side, and we have still production of these scissors, these anticoagulating factors, but they are not enough to stop, to block this coagulation. And if you look at the patients with different severity of disease, distinguish between mild disease till severe disease, we also see their increasing disbalance between coagulation and anticoagulation. What can we do? First of all, we can try to exchange the plasma, exchange the soluble part of blood, and take out from the circulation all these hyperproductive coagulation factors, and also take out all the cytokines, all these inflammatory molecules that produce this immunothrombosis on one side, and we can also exchange it by the fresh plasma that has enough, a normal number of coagulatory factors and no high level of cytokines or inflammatory molecules. We can also provide anti-inflammatory drugs, as Carmen told us before, and we can also provide really special anticoagulant drugs like scissors, I told you before, that prevent that help to provide anticoagulation. With that, I would like to give back to Jörg for the next presentation. Thank you for your attention.
Thank you, Nina. We would like now to shift the third impulse that is going to be given by Professor Yehuda Schönfeld from the Tel Aviv University. He is founder and head of Sabludovic's Center of Autoimmune Diseases. He is giving us his view on autoimmune and challenges that we see here in that specific aftermath of the COVID pandemic. And you will do this without slides, but as a talk. Thank you very much for being with us.
Thank you very much, Georg. So the COVID-19 is an autoimmune virus, as we have reported in the paper at the very early stages of the pandemic. And the post-COVID syndrome is an autoimmune sequelae of the COVID virus. Autoimmune diseases are characterized by the fact that the immune system is attacking your own constituents, organ, tissues, cells, and so far, instead of attacking foreign invaders like viruses or bacteria. Autoimmune diseases, by and large, are all genetics. The genetics means that you are born to a family which has a very aggressive immune system, beneficial immune system. However, you need an environmental factor to induce autoimmune disease, and the characteristic of the environmental factors being viruses, the sun, aluminum, or whatever, is hyperstimulation of the immune system. So when it comes together with a genetic background or being a younger woman with an hyperactive immune system, women have a better immune system than men, then autoimmune diseases will ensue. That's the reason, by the way, that 83% of autoimmune diseases are found in women. And also it was mentioned that the post-COVID is more prevalent in women than in men. So the COVID syndrome is actually an ideal agent to induce autoimmune disease in genetically prone people. And that's the reason why not everybody develops the post-COVID syndrome, only 1% to 2%, maybe a little bit more. And the COVID-19 hyperstimulate the immune system, and we know how it hyperstimulates the immune system. There is a second mechanism which will determine which autoimmune disease will develop, and this is the molecular mimicry. The spikes of the virus are similar in structure to many of our constituents in the body. So when the immune system attacks the spikes, then it is redirected against our own constituent. So it's not surprising that we have reported that following the COVID-19 syndrome, more than 20 different autoantibodies, missiles against our own constituents, were reported. And therefore, it's not surprising that more than 25 different autoimmune diseases were detailed to follow the COVID-19 syndrome per se. Now, what came after was very similar and was mentioned by Professor Scheinbogen to other viruses which hyperstimulate the immune system, like the kissing disease virus, the EB virus, or the cytomegalovirus, and many other bacteria. We have an increase in incidence of different autoimmune phenomena, including chronic fatigue syndrome or fibromyalgia, which quite often you can find viral attack earlier before the emergence of the disease. So what characterized the post-COVID syndrome was delineated by Carmen: peculiar manifestation, muscle pain, memory loss, cognitive impairment, that suddenly we, the physician, cannot explain them. We can explain them. And this is a novel aspect that was revealed in the last 2 or 3 years, basically by the German physicians, but also in other groups. And this is emergence of autoantibodies, missiles against our own constituents. And in this case, it is the autonomic nervous system. It's not the regular nervous system in which you put your finger in your nose and then you take it off, etc. Autonomic nervous system is everywhere. It is in our muscles, it's in our cells, it's even in the small nerves in our skin. And what happened is that these autoantibodies affect the 2 arms of the autonomic nervous system, adrenergic and acetylcholinergic. They are in balance. When we wake up or stand erect, something autonomically arrange our heart rate or blood pressure. When we sweat, it's done autonomically. When we sleep, things happen autonomically. And therefore, these autoantibodies disbalance the autonomic nervous system. And therefore, we have the cognitive impairment, the widespread pain. We have also the memory loss. We have sweating derangement, as well as even hearing loss and hair loss, etc. So we have the autoimmune mechanism deals or based on the hyperstimulation and molecular mimicry of the virus. We have a post-COVID autoimmune phenomena, which are almost identical to the fibromyalgia, as well as the chronic fatigue syndrome, in which we can find the autoantibodies. We need to do more studies because there are 18 different autonomic autoantibodies, which some may cause the sleeping disturbances, the other may cause the widespread pain, etc., and to find the correlation. So now we come how we shall treat this autoimmune phenomena. Like we deal with other autoimmune phenomena. They are sophisticated therapy, expensive therapy by monoclonal antibodies, which are directed specifically against the cause. We have a compound called IVIG, intravenous gamma globulin, which is the good missiles from 20,000 people, quite expensive, but affordable, which has been found to be already effective in COVID syndrome and in post-COVID syndrome. But there are also other cheaper modalities to immunomodulate the immune system, actually to inhibit the attack against our own constituent. Let's say vitamin D. Vitamin D is very effective as an immunomodulator. And those who suffer from lack of vitamin D, they are more prone to develop autoimmunity. Vitamin D almost has no side effect. It's very cheap, so why not to use it? There are other constituents like other ingredients in our food, like curcumin or curcum, which may also immunomodulate our immune system. Last but not least, it was already mentioned here, rehabilitation by physical activity. somehow progressive exercises can improve the condition of those patients. They are cheap. We hope that we will not need more sophisticated therapy, which will be directed against those autoantibodies which are affecting our autonomic nervous system. So in summary, the COVID-19, except of being very deleterious to the lung and to other tissues which contains angiotensin converting enzyme, is a hyperstimulator of the immune system, like the kissing disease virus, EB virus. It induces autoantibodies, it induces autoimmune diseases, and then it also affects the immune system for a long time, and then the autoimmune disease can last forever. Therefore, we have to redirect to inhibit the attack on our immune system by more sophisticated facilities or by simple ingredients, as I mentioned before. Thank you very much for your attention.
Thank you very much, Yehuda, for that inspiring statement. And now I'd like to come to our fourth speaker, Professor Dr. Ross Safonte. He is from the Harvard Medical School. He is chairman of the Department of Physical Medicine and Rehabilitation and interim president of Spalding Rehabilitation Network. And he's at the East Coast in Boston. And Ross, thank you for sharing your thoughts with us. I know that you have also been hit quite hard by that COVID event, experience, disaster. And you're sort of one of the hotspots where people go, especially in to seek then rehabilitation in the long run. Thank you, Ross, for joining us.
Thank you, Jordan. Thank you for the entire group. These were stunning presentations, and what I'll try to do in the next 10 to 12 minutes or so is sort of give you our thoughts about the phenotyping, having seen a lot of these people and some of the novel therapies linked to, but a little plus up from what my colleagues have talked about. Let's see here. Yes. So these are my disclosures, which we're obligated to do in the United States, none of which are related in any way to this presentation. Okay, so what I'm going to try to do is give us an ordered way to think about all of these remarkably complicated and intertwining symptomatologies. And many of them shouldn't surprise us, as was discussed. ME/CFS is similar, and I would argue that people who are post-sepsis from the ICU are very similar. Organ system, constitutional, and functional systems. We'll talk about recommendations, and Dr. Schoenfeld has done a lovely job of outlining many of those, and then long-term concerns and questions. I would just bring up to you that Professor Summers, who was once president of Harvard and secretary treasurer of the United States, did an estimate in October of 2020 that the cost so far of COVID was 16 trillion US dollars. And I would suggest that the long-term cost of this, as my colleagues have laid out, will be remarkably higher. So this is a paper that was recently published in Nature Medicine, and it gives a very good cartoon-like look at what has gone on, the multi-system effects and the durational time of what has gone on both in the acute and post-acute issues of COVID, laying out many of the issues that have been discussed regarding symptomatology and timing. We tend to like to call this PASC, or post-acute syndrome of COVID, or long COVID, and divide these into organ system complaints, constitutional complaints. That might be fatigue, that might be myalgia, that might be arthralgia, and functional limitations. And so if you look at this modeling, we look at this post-acute and sort of PASC 12-week or 3-month model. And this could be, as my colleagues have said, viral infection. Inactivity is a big issue. You lose 12% of your strength a week if you're not active. That is stunning. You replicate that many weeks, it's a huge issue. Hyperinflammatory response, microvascular disease, hypoxic or hemorrhagic issues. I'll talk about that when I go up to the CNS. Transsynaptic spread, white matter changes, and social isolation. And in this recent paper, this was a systematic review by Graf et al. In JAMA Open. They look at PASC frequency. Short term is around a month. Intermediate is 2 to 5 months, and long term is greater than 6 months. And what you see is percent frequency here. This is enormous. This is nearly 50% in some of these studies that people have long-term at least one PASC symptom. But there may be many constructs to that. I'm going to take on now some of the organ-based system complaints. This is PASC frequency. And if you can see, you see chest imaging abnormalities, oxygen use, dyspnea, ground glass appearance. You see a lot of respiratory persistent symptoms in this population of people. But as Professor Schoenfeld said, we obsess on the lung and to some extent the cardiomyopathy, myocarditis, sinus tachycardia related issues. But we believe, and there is a growing series of evidence clinically, we have a study going on now here in Boston, looking at the responsivity of people in various exercise and other testing, that this theory of dysautonomia related to long-term symptomatology is spot on. There are afferent barrel reflex issues in the medullary structures that are inordinately attacked with SARS-CoV-2. And what we're seeming to see is a dysautonomia that persists, some of which may be related to viral toxicity, inflammatory response, and frankly, disuse over long periods of time. Now, if we move to the neurologic system, which is one of my passions, and we look at two things, I would say they are underdiagnosed and underappreciated. And that is this persistent complaint of memory deficits and difficulty concentrating and cognitive impairment, and on the behavioral health or mental health disorders, anxiety and PTSD, as well as depression. Please look on the x-axis at the rates of this PASC frequency with memory disorders, difficulty concentrating, anxiety, sleep, and PTSD. The numbers are quite stunning, but reasonably not that different than people who've spent a long time in the ICU with sepsis. The difference may come in those with milder cases. And so there's a series of papers trying to quantify what the real stroke rate is related to the microvascular issues my colleagues have brought up. And the stroke rate seems unclear. The original reports of 8 to 12% from China seem overdone, at least in North America. And what we're seeing is rates much less than 4%, perhaps less than 1%. That may be also what we've learned about early anticoagulant therapy and oxygenation. But more concerning is this fairly recent paper from the UK, in which they found, among those who survive COVID and go on for some period of time and have had a prolonged stay with it, pretty significant brain atrophy in the left insula, left orbital frontal, left parahippocampal gyrus. That is deeply concerning. And when you can show that level of atrophy, it suggests there may be, to Dr. Schoenfeld's point, a group of people who could be immune genomically vulnerable to further deterioration, even white matter tract deterioration. I show you here this recent study from our friends at Mount Sinai, in which they looked at 740 subjects and they did neuropsychologic testing. These are people who had various levels of SARS-CoV-2, people who just came to the ED and were diagnosed or treated as an outpatient, and then those who were hospitalized versus outpatient. And what you see is pretty significant loss of processing speed, executive function, phonemic fluency, and attention, which is worse in the hospitalized patients. but preserved memory recognition. This is a pattern that is consistent with executive function disorder. There might be possible biases in this study, i.e. those seeking care, but still all in good. It raises another level of concern. Now, in this constitutional symptoms cohort, one of the things that we persistently see, and was described all the way back to the Carfey article, was fatigue, fatigue, fatigue. Fatigue comes from many issues, often seen obviously in ME/CFS, but it is representative of these viral inflammatory syndromes and may also be representative of a number of other issues that may be common drivers. I just point out quickly that because of prone ventilation, at least in North America, we saw a large number of people with compressive neuropathy, some of which are nearly permanent or semi-permanent in damage. And then to go along with many people's concerns, this prolonged either steroid use early on, which is used less, neuromuscular blockade, the impact of a sepsis-like picture produces profound muscle atrophy. That muscle atrophy is associated with poorer function, mortality, and this is someone we happen to have had a prior lateral thigh MRI on pre and post, and you can see the level of the atrophy is just simply stunning. And near lastly, I'd just like to take on the issue that many of our patients, as has been represented in the literature, probably because of inflammatory related issues, complaint of myalgias and arthralgias. The prevalence of arthralgia or myalgia is very high, 15, 17, 20%. There are a few cases of rhabdomyolysis and a lot of proximal myositis, all suggesting the common mechanistic drivers that I'm noting here that our colleagues just described. But here's an issue that people didn't take on quite yet. And I think it is profound and plays so markedly into what we see overall and impairs functionality. And that is this issue of post-illness behavioral health disorders. Some of the early data was showing 30% rates of PTSD, high odds ratios for depression, anxiety, stress. And I show you simply this older slide that looked at the prescriptions in this population in the United States for depression and anxiety during the early part of the pandemic. They are remarkable and striking. We should, however, remember one other thing. When we tell people a lot about an entity, its evils, and how many people are going to get it, there is a real genomic predilection as well as inculcation predilection for nocebo effect. If you tell college students that this benign entity will induce pain, a large number of them will have it. Nocebo nebulizers can induce asthma. Nocebo injections can cause food allergies. So while I think this is an incredibly real entity driven by primary pathologic processes with secondary behavioral health disorders, some of which may be linked to white matter disease and other entities, I do think we need to recognize that overemphasizing this, and we don't know how much to emphasize it, can have a generalized nocebic effect, especially among those with milder injury. So we've looked at function in this population of people, endurance, gait speed, independent transfers, all of these entities. And what you can see is that there are really significant abnormalities and functional impairments, mostly significant mobility declines, exercise tolerance, and functional impairments that seem to last nearly a year or over. We see similar sorts of impairments among those with prolonged ICU stays and sepsis. Here's some pre-publication work, so please don't publish it, from my colleague Joe Giacino, who's leading our recovery study. This is 6-month data. These are all NIH-related metrics and Z-score transformations, but you can see among the most symptomatic people, their metrics of physical functioning, pain, fatigue, and sleep are declined. Here you can also see emotional functioning with depression being, look at that, hugely impaired, anxiety and stress disorder. So if I think about how we approach recovery, it's exactly as was said before. We need to define the phenotypes or as some people say, the endotypes. Multidisciplinary assessment is warranted. Not everybody, as I show in the American saying, a hammer and a nail needs the same thing. Team-based care helps. Progressive aerobic activity in a graded manner seems to be reparative. We need to treat and understand the behavioral issues. Fatigue is an important and limiting element. We need to pace, plan, and prioritize. Cognitive fog is an issue, and I'll talk a second about that. And there are rules for various medications, some of which may be immunomodulatory, some of which may be symptom treatment related. And so here I give some quick ideas about spaced aerobic training. Some have advocated for ozone or hyperbaric oxygen-based therapies, which we have some questions about. A focus on fatigue and concentration with compensatory or other techniques. Nicotinamide riboside seems to potentially be helpful in Alzheimer's related to mitochondrial energetics and may be protective in this kind of scenario. My colleagues at MGH Neurology are doing a trial in that. Atorvastatin has been postulated. It has a generally thoughtful possible protective effect in chronic head injury. Amantadine and methylphenidate have been used for treatment of fatigue, especially amantadine, an older fatigue and antiviral agent, and novel therapies such as anticoagulants, immune-based therapies such as IVIG. So my questions are, what are the primary mechanisms for long-term COVID dysfunction? You've heard many of them. What endotypes are most at risk within severity categories? What is the role of mood, isolation, and declining behavioral function? And in reality, what are some nocebo effects? Can COVID lead to long-term cognitive decline among those with severe and even mild? And who's at risk? What are the mitigatory effects of early monoclonal antibody treatment or antiviral interventions? And even what happens to those who are immuno at risk who break through vaccination? So thank you very much. And it was a pleasure to spend time with you.
Thank you, Ross, for your inspiring right through the broader spectrum even, and giving us a hint also to the neurological aspects. Now we would like to open the floor first here among us and then allow also questions to join us. While all of you have gone quite a bit in the same direction to some degree, there are some specific differences among your statements. And I would like to come to some of those. And I would like to start probably with the theme of diagnostics, diagnosing the patient. So while we are probably well enough equipped at the moment to identify the patients that are suffering from an acute COVID phase, we don't really, what is your thought about how do we identify, diagnose long COVID situations in our patients? Is here a common understanding? We had the statement from Carmen that there is now a consensus line. Is that now sufficient? Is that point done? Do we have enough diagnostics established at the moment? Or if I listen to some other statements, especially the last one, makes me a little bit think about, are we seeing the patients, are we able at the moment to identify the patients early enough to have a proper treatment possibility? Or is it still that they accidentally are finally then diagnosed of being COVID-19 long-term challenge patients? Any statements, Carmen, from your side, for example?
Yes, I may start. Actually, these are several questions. Well, coming to first of your first question, how to diagnose disease. I think this is most challenging in the youngest, in whom we have actually no evidence for organ dysfunction in the majority. Therefore, in these patients, we need to look deeper, and we need to do tests we do not usually do in most of our patients. For example, the fatigue, and we learned that the majority of the post-COVID patients do have both mental and muscle fatigue. So you can assess this with simple methods like hand grip strength, and that is really frightening to see that young people 6 months following COVID lost more than half of their hand grip strength, although they were quite mildly infected in the beginning. And then, Ross, you mentioned the autonomic dysfunction. That's again a major symptom in these patients. And there's actually one tool, which is just a questionnaire as a screening tool to assess the function related to bowel function, to breathing, to heart rate, to sweating. And if this is positive, then you can do more sophisticated tests like assessing heart rate variability. Again, a very simple test for assessing autonomous dysfunction is just measuring the pulse rate. Sitting pulse rate is usually increased, and the standing pulse rate is even much more increased. Some patients fulfill that criteria for postural tachycardia syndrome. So, and then the other big issue is, of course, can we identify these patients early, and do we probably have early preventive strategies? And that is something I think we should discuss as well. Actually, there was this very interesting study published in the Lancet, the Oxford study with budesonide spray in those who had cough. That was not a very well done study, but it's her first idea that probably preventing these long-lasting inflammation in these patients when the viral infection has resolved may also prevent long COVID.
Yeah. So these are the very important questions: how to diagnose. The second one, how to treat. When you go to EB virus and the post-EB virus syndrome, which was not called syndrome because it was diagnosed usually post-factum. You can trace the patient blood, let's say in army repositories, and find that they had an EB virus. So the best thing is the prevention. And luckily enough, most probably they are developing now drugs which will prevent the binding of the virus to its receptors in our body. But now coming to those who had the COVID syndrome, and by the way, Ross mentioned also the vaccine. You have the same syndrome after the vaccine, or the vaccine contains also the spikes and the molecular mimicry and so forth and so forth. So those who recovered from the acute COVID syndrome and then develop the post-COVID syndrome, it's easy because it's like the recurrences of the fatigue, of the post-tachycardia syndrome, etc. So it's easy if you have a lag period when they recovered, and then the autoimmune study emerged. But those who had a continuous follow-up, it will be difficult. They do not recover. So we need a subjective parameters. And I would like to suggest currently two subjective parameters. One is the autoantibodies. If they persist, like in other autoimmune diseases, we diagnose the autoimmune disease on the basis that we have these autoantibodies, and most probably we will refine our diagnostic parameters, which autoantibody. The second, that I believe will be a small fiber neuropathy. Small fiber neuropathy is diagnosed by biopsy of the skin in the leg, or there are more sophisticated system today to see it on the eye. The results of the attack of these autoantibodies the results are attack on the small fibers in our skin, and they disappear. And that's part of the reason for the paresthesia, for the weakness, for the widespread pain, and for other things. They can reinstitute themselves when the subject is recovering. So it may be also a subjective parameter to recovery from the syndrome, or a clinical parameter for those studies to find a better therapy for this syndrome. So we need the time frame of the emergence. We need a list of symptoms, as was mentioned both by Carmen and by Ross. And last but not least is subjective parameter, which we put in diagnostic criteria, major and minor.
I'd like to follow up on that, Yehuda, what you just said, because we have here also a question that came in the pot. What you just mentioned as two possible diagnostic pathways, is that based on that is based on data that you have raised in your institution? If you can elaborate a little bit, because the question was here, if the statements from your side are proven or just ideas.
Okay.
And I think I know that there are more than just ideas, and that's why I would like to stress here or invite you to give a little bit more backbone here.
Thank you for the question. So let me explain. There are already data about the autoantibodies, and we have already some data about the skin biopsies and the small fiber neuropathies. But we have to understand that there is a group of diseases which most probably are more expertise by Ross and Carmen, and I would like to delineate them. Mm-hmm. It's called chronic fatigue syndrome. So to speak, idiopathic. What is idiopathic? That we are idiots that we don't know the pathology. But most probably it's previous viruses, etc. There is sick building syndrome, which is when they leave the building, they repair. They have the same clinical manifestation of fatigue, foggy feelings, memory loss, and etc. And recently we have published extensively on silicone breast implants. And surprisingly, those who are genetically prone, among the women who are silicone breast implants, have the same signs and symptoms which we didn't have explanation. We have sent the patient for MRIs, CTs, etc. And then we say that they have something in their brain. No, we know what the reason. It's autoimmune attack induced by the adjuvancy of the silicone. And therefore, when you do the analogy, all this group were mentioned in the lecture of Ross. We call it dysautonomia, disbalance between the autonomic nervous system. And therefore, both Ross and I believe also Carmen mentioned the word functional. And this is function because there is imbalance. We have to bring the balance back to the autonomic nervous system. So to your question, we do not have yet final results that we can establish it as a rule, but it looks like it is leaded to this result, similarity to other similar conditions that we know in the clinic.
Thank you for clarification here. That was, I think, very important. With those sort of possible strategies and eventually practiced strategies, probably a practical question. Do we see those patients at the moment, whereas still at the beginning of that whole scenario, but do we tend to see the patients too late, or do we see them probably at too many diverse places? That's a discussion that we have also internally. Are we sort of good enough in entering or allowing the patients to find the right advice on the medical side that the problem meets the solution? Or and to what degree is time playing here an issue? Brief statements from your side would be super helpful. Probably us starting first and then Carmen.
So thank you, everybody. And I just want to thank everybody for what were great talks. I guess my sense is that we have found that getting people early is better than getting them later. And so over a period of time, ourselves, our colleagues in New York and out in California, as well as many other places, have developed these comprehensive post-COVID clinics that are multidisciplinary, where multiple different views can be taken, from immunogenic to therapeutic, trying to do three things. One is better phenotype the persons. Two, deal with this comprehensive set of the issues that people have. 3, try to symptomatically treat people until we have what is approved or even insightful therapeutics outside of clinical trials.
Well, I agree that we see, at least in Germany, patients much too late, but that is a structural problem because there are so many patients and we cannot handle them in specialty clinics all at the moment. And then in the primary care, there is often very little knowledge how to handle these patients. Therefore, one important issue now is education. So we need to help the primary physicians. I recommend that patients who have ongoing symptoms beyond 4 weeks should go to their GP and they should screen for treatable diseases, and they should decide if they need to send the patient to a specialist and then finally to the university. And regarding treatment, I think that must be tailored. So we have patients, a subgroup who has post-exertional malaise and get much worse when they do physical training. For these, we need to teach pacing, and the others who have fatigue and can stand activity, for them probably activity is the best recommendation at the moment.
Yeah, I agree. I think the problem in Germany is not unique to Germany, and the United States. Our queue list for getting into those clinics is amazing. We've had to add people, and we just don't have people to find anymore.
Probably since exercise has been mentioned from you a couple of times, remembering that we saw some of those patients, and in some it may be the solution, in others it may probably be counterproductive to suggest exercise. So how do you separate and really get the right fit to each individual? Is that something that at some point will be at the level of the general practitioner available as knowledge, or do we need autoimmune antibody tests that allow us to differentiate patients more proper?
So I will, as a clinician, I would refer to this question. It's also very difficult to convince chronic fatigue syndrome patient to start with exercise. It's not easy. Actually, they are classified into 2 groups, those who would like to do and those that a priori would not like to do. So I have a trick, but as you know, I'm coming from Israel, which is a sunny country and warm country. And the trick is to put them into water. It's much more easier to convince them to do exercise in the water when the weight is lighter than, and those who respond to my request or suggestion, they follow up on it. And it's interesting that even after a year or 2, when they stop the, so to speak, hydrotherapy or swimming, whatever, the symptoms may recur. Is it because the presence of the autoantibodies? We don't know. We will have to follow up on it. Regarding the follow-up clinic, we do a skin biopsy to every patient, if needless to say he agrees, and we measure the autoantibodies. So I hope that very soon we will know whether they are indeed the best subjective parameters to the existence of the disease, and most probably also for the recommendations.
Ina,
Yeah.
sorry. Any thought from your side in terms of novel diagnostic perspectives? What would you sort of complement here?
Well, as already Huda told, there will be the kind of antibody profiling that will allow us to differentiate between patients who are prone to develop such in advance to develop such pathology, and that are just recover without any problems on the basis of autoantibody or T cells. But so far as I know, there are no such biomarkers that allow us to differentiate between these patients, unfortunately.
Carmen, you wanted to add?
Yeah, I wanted to add regarding pacing. Pacing is really a challenge for both physicians and patients because it's different in each patient. So some patients can still do some form of exertions, and then water therapy, for example, may be very helpful. But there are others who can hardly care for themselves. And in those patients, minor exertion may lead to severe crashes called post-exertional malaise. And in these patients, it's really important that we recommend pacing. during the first period, at least, because we have learned from ME/CFS following other infection that in those patients, permanent overexertion can worsen the disease.
So that's why I think it's so important for us to really think in the future to having various endotypes or phenotypes of people that are complemented by not only diagnostic responsiveness to various physical and other challenges, but a series of biomarkers that will help us define people's trajectories and paths. And I think that in the future may be the way to go. I would just add to Dr. Schoenfeld's comment that we also use pools and in the reality of the issue is some of this exercise can also be an anxiolytic and an antidepressant.
Yeah, I think that's a very good point that you made, Ross, that there is quite a bit of a variability in the spectrum still to be also covered. We have a question in the online forum, and I'd like to also invite everybody who's joining us, if you have questions, to use that online forum or here in the auditorium to stand up and use a microphone and come if you have questions. The question is from Kay Bear. Fantastic talks from all participants. Thank you to all of you. Applause. I'm very encouraged. The question, when do we start to call a post-COVID syndrome, which lasts longer than 6 months, an ME/CFS? I think that goes a little bit also to Ross. Is that true? Or who would like to take that?
I think Ross and myself can answer. Ross, please be first.
Carmen, go ahead, go first.
Well, we have diagnostic criteria actually for ME/CFS, though that's a chronic disease. Therefore, it shouldn't be diagnosed before 6 months. But then one should consider it in patients who have fatigue and post-exertional malaise as key symptoms. And then there are screening questions from EOM. And then the diagnostic criteria we recommend in Europe now are the Canadian consensus criteria from 2003, which are quite specific and helps you really to make the diagnosis.
Can't agree more. We use the Canadian consensus criteria as well. I would just add that in our center, we don't label it. We label it ME/CFS-like syndrome because we don't know if it's directly independent or directly linked.
Thank you very much. We have another question from Kay Bear. Other questions to Yehuda Schoenfeld. Would you be please so kind to name exactly which autoantibodies are you measuring in your patients during the hydrotherapy? So that's a very specific question then. Or would you use their different ones than in the other activities?
First, it will be interesting, and thank you for the suggestion. We might follow up the titers, the level of the autoantibodies before and after therapy, whether it's very interesting for me as an enigma, how exercise, progressive exercise, improve the condition. But since we are dealing with the autonomic nervous system, exercise affects the autonomic nervous system. We know that adrenaline is stored when we are exercising. But I would like to take this advantage to mention something very important. And because I'm not such an expert like Carmen and Ross, only in chronic fatigue syndrome, I'm a poor internist, I call it fibromyalgia or chronic fatigue syndrome. And recently there was a very, very seminal paper in the Journal of Clinical Investigation, in which they have isolated the autoantibodies from the fibromyalgia and injected it to mice, collaborative mice. And the mice actually developed signs and symptoms of fibromyalgia, a sensitivity to pain and to heat, etc. This is an indication that it is autoimmune and the autoantibodies are causing. I would like to mention a seminal paper that was published by the famous professor sitting next to me, Professor Carmen Scheibbogen, in which he took 10 patients with chronic fatigue syndrome and plasmapheresed them. She took out the autoantibodies, and 9 out of 10, if I remember well, actually recover. So we have the scientific evidence that these are the autoantibodies that cause it. So we should use them for diagnostic purposes, for follow-up, and also for attacking them as a therapeutic measurement.
To provoke here a little bit, that sounds to me quite a spectrum. You had the vitamin D mentioned.
Yes.
You have mentioned now sort of filtering out the antibodies as a probably very harsh method. And you also mentioned that there are maybe not only genetic dispositions that could cause a more challenging path of the disease, but also that there might be a link to our food habits and living habits. So to leave that to a slightly different perspective, would you expect that also we will see post-COVID more pronounced in certain regions of the globe compared to others due to habit differences that we have across people? Or is that at the moment something that is so dramatic in itself that the local differences and variations of our habitual constraints are not really impacting the progression of the disease or the risk of a post-COVID?
So there are studies. Let's start with the genetics. There are already even genetic markers which make you more prone to develop both the COVID infection and most probably the post-COVID syndrome. Like those who determine, it's called HLA, DRB1 haplotypes and some genes, etc., which indicate that you have a hyperstimulated immune system, as per the vitamin D. I have expected that we would have in the more modern countries more, let's say, infections with the COVID-19. Then, for instance, in South Africa or near the equator, the problem is that the Germans have lower level of vitamin D. The Israeli in the same country, because they are always in the air-conditioned rooms, they are always in shades, etc. So they also suffer from low vitamin D. And on the other side, I have to say, this virus surprised all of us. Whatever I predicted, I was disappointed. I was not right, and my wife was right. So it is so infectious. We didn't have such an infection that it may overcome these small differences in environmental factor. This does not mean to say to improve our diet by adding vitamin D, curcumin, and other things. We will learn more about even the microbiome of those patients, how it affected different things, including, Dr. Ross, the neurological aspects of the virus.
I would like to come to the last part of the session in terms of the dimension of therapeutic possibilities. So let's assume the patients survived the acute phase. We know that more of those with severe pathways through the acute phase would probably show up with long COVID effects. We also know that mild path of the disease could lead to post-COVID situations. Nina, from the perspective of advanced therapies and possibilities, where would you see, you nicely showed that CD4, CD8, which I like a lot in the interplay and the disbalance, and would you see that as a target for advanced therapeutic strategies? You mentioned briefly the regulatory T cells. Could you extrapolate a little bit about where you see, beside what we have heard already, future possibilities to treat those patients in remaining post-COVID phases where simple exercise doesn't seem to be appropriate and the right fit?
Thank you, Georg. Very nice question. Actually, talking about the pandemic, this is probably the advanced therapy coming on the last place, because we need to provide this therapy to mostly everybody in the world. But if we have a possibility to provide this targeted therapy, it would be probably the therapy of choice for me, because in our body, we have like an interaction between pro-inflammatory and anti-inflammatory arms. And this regulatory T cells is a kind of police cells. They just control overwhelming immune reaction that just stop our body just start to produce too much of inflammation. These cells can control this overwhelming inflammation and very specifically. And therefore, this kind of therapy will try to stop this unbalanced and unwanted, and what I want to say, unwanted overwhelming immune inflammation on one side, and keep all other inflammations that we need to prevent other viruses or other pathogens, keep it in normal, but just take this overwhelming inflammation in case of COVID-19 and diminish this. And it would be therapy of choice for me. But as I told you, it's a very specific therapy, needs a lot of strengths and can be probably taken of a very small amount of laboratories that are allowed, or they can do this. Yeah.
The other perspective that you mentioned at the end of your talk was the immunothrombosis theme and topic, and we haven't really touched on that. Where would you see that? Is that something which is basically causing consequences that really link then to the post-COVID problems and clinical pictures that we see, or is that something that is at the end of the acute phase, probably doing more harm, that then in the consequences have to be treated and are targeted? So, so where would the therapeutic strategy would be there? Is it something that belongs more to the acute phase, or would you also target that in the later post-COVID phase? So
exact mechanism, as far as I know, is not known so far. And of course, itself of acute is known, but for the post-COVID situation is also suggested. And there are, so far I know, the studies on post-COVID, acute situation, that this therapeutic intervention help to prevent late consequences of post-COVID. But as far as I know, for post-COVID, there are no such studies that help to prevent such symptoms.
Any questions?
Yeah, well, I can just briefly add to it. We analyzed our post-COVID cohort 6 months after infection. So there is actually evidence of endothelial dysfunction, which you can measure, for example, by EndoPET in up to a third of the patients. And we have evidence for low-level activity of coagulation. So a subset has elevated D-dimers, and there are other studies showing that some patients even do have microthrombi. So this is something I think we should focus on. And this is probably a different subset than those where we have autoimmunity ongoing. And my big hope is that we have in the near future a signature of autoantibodies, which we know is related to the symptoms, and then that we can target these. And there are emerging therapies which may offer treatment for the majority of patients, for example, FC receptor targeting or neonatal FC receptor targeting drugs are in clinical trials now. And if I may add one point, the problem with these autoantibodies against autonomic receptors, Yehuda mentioned, the problem is that these are actually natural antibodies. So actually all of us do have these autoantibodies, and they have a physiological role in regulating stress responses. So it's not just a yes or no as we have with other autoantibodies, but it depends more on the level and even more important on the functions and the disturbed function probably of these autoantibodies. And for example, in EBV triggered ME/CFS, we see at least that the higher the level of these antibodies are, the more symptoms the patients do have. Still, it's difficult to make from this a firm diagnosis. So there we need to do some more efforts so that we can use these antibodies as a sure diagnostic criterion.
Also, would you like to add something from your perspective? Would you see a similar spectrum? Do you see other compounds coming, like in repurposing strategies at the moment emerging?
Yeah, so what I almost think we need is of course, enhanced phenotyping, as we've all said, and in a biomarkers portfolio to be able to track things, but almost a platform trials kind of scenario. So an idea in which people can enroll in multiple different potential arms, because I think that there is, under the organ specific, a lot of autonomic, but also cardiopulmonary. And you know, my own bias is that we have a lot of neurologic and other entities to combat. And so I think that we have early intervention, we have immunotherapies, we have symptomatic treatments, we might have neuropreservative sorts of treatments. And I think that not everyone is going to need everything, and not everyone is going to benefit from everything. And so defining the various phenotypes or endotypes is really important, but developing an international network in which we can use common diagnostic characterization and a platform of trials to be able to enroll people to understand how we can change the curve of their functionality, because in the end, that's what it's all about, is probably the way to go.
Thank you, Ross. So thank you to all of you here on the podium. We were running to an
one point to Ross, because he's the only one who recovered from the infection itself, the COVID infection itself. So from your wonderful talk, I have to say that you have no cerebral atrophy. So good luck.
So Yehuda made the point. So thank you very much to all of you, and also to Carmen and Nina for the wonderful talks. And what I take for myself from that session, and I hope you enjoyed that also here, the people here in the room as well as online, we need to learn more about the phenotyping. We need, I like that idea. We need to have multiple trials, or organizing the trials that are ongoing in such a fashion that we really come to more specific characterization possibilities for an individual patient. The diversity of the disease needs to be addressed. We see at the horizon, and actually very practically, Carmen pointed that out, a number of repurposing possibilities that might easily in the next couple of months, or hopefully less than 1-2 years, lead to therapeutics that could be used in larger group of patients. But there will be a number of remaining groups that probably need advanced therapies, immunotherapeutic strategies, and we certainly will target the aspect of exercise and vitamin D. I still have the picture from the muscle atrophy that Ross showed in my mind. There is a lot then to recover. So the earlier we target the patients, the earlier we identify them, the less they have probably lost, and the better we can target them and help them. Thank you very much, everybody, for joining here. And I hope you have a great day today here at the conference, and a regular work day was for you. Have a good day at the East Coast, and thank you for joining us here.
Thank you all.